Ovarian cancer staging, classification systems, and clinical significance. Ovarian cancer staging determines disease extent and guides treatment decisions. The FIGO system classifies tumors by location, spread, and metastasis to direct appropriate clinical management. Understanding cancer staging and its clinical purpose. Cancer staging represents a fundamental component of oncologic practice that establishes the anatomic extent of malignant disease at the time of diagnosis. The staging process involves a systematic evaluation of multiple variables that collectively describe how far a cancer has advanced within the body. This assessment provides critical information that influences treatment selection, predicts patient outcomes, and enables meaningful communication among healthcare providers. By assigning standardized categories to tumors, clinicians can compare outcomes across different patient populations and tailor therapeutic approaches to match disease burden. The staging classification also facilitates prognostic counseling, allowing physicians to discuss realistic expectations regarding survival and treatment side effects with their patients. Core components of ovarian cancer staging. Ovarian cancer staging incorporates several key anatomic parameters that collectively define disease extent. The primary tumor characteristics examined include the size and local invasion of the lesion within the ovary itself. Clinicians assess whether the malignancy has breached the ovarian capsule and invaded adjacent pelvic structures such as the fallopian tubes, uterus, bladder, or bowel. Regional lymph node involvement represents another critical staging element, encompassing both pelvic nodes adjacent to the primary tumor and paraortic nodes situated along the abdominal aorta. The assessment also determines whether cancer cells have disseminated to peritoneal surfaces throughout the abdominal cavity or have established distant metastases in organs such as the liver, lungs, or pleura. This comprehensive evaluation requires coordination between surgical exploration and radiologic imaging modalities to accurately characterize disease distribution. The FIGO staging system for ovarian cancer. The International Federation of Gynecology and Obstetrics, FIGO, has developed the most widely utilized staging classification for ovarian cancer, which has undergone multiple revisions to incorporate advances in understanding tumor biology and treatment outcomes. The FIGO system categorizes ovarian tumors into 4 principal stages, designated as I through 4, with subdivisions within each stage that further refine prognostic precision. Stage I encompasses malignancies confined to one or both ovaries without extension beyond the ovarian tissue. Stage 2 describes cancers that have extended to nearby pelvic structures but remain within the pelvis proper. Stage 3 indicates disease that has spread to abdominal peritoneal surfaces or regional lymph nodes beyond the pelvis. Stage 4 represents the most advanced category, encompassing tumors with distant organ metastases or pleural effusions containing malignant cells. The current FIGO classification system underwent substantial revision in 2013 to better align staging criteria with contemporary surgical practices and improved prognostic accuracy. Stage I ovarian cancer, localized disease. Stage I ovarian cancer refers to tumors that remain confined to the ovarian tissue itself, representing approximately 15 to 20% of newly diagnosed cases. This category subdivides into 3 levels based on extent of ovarian involvement and capsule integrity. Stage IA involves unilateral ovarian malignancy with intact capsule and no intra-abdominal spillage during surgical manipulation, representing the most favorable prognostic subcategory. Stage IB encompasses bilateral ovarian involvement or stage IA disease complicated by rupture of the ovarian capsule. Stage IC includes any stage IA or IB disease with malignant cells identified in peritoneal fluid or washings collected during surgery, suggesting microscopic dissemination despite the absence of visible metastatic disease. Patients with stage I ovarian cancer generally demonstrate substantially improved survival outcomes compared to advanced stage disease, particularly when tumors are grade 1 or grade 2 differentiation. The distinction between these substages guides decisions regarding chemotherapy administration, as stage IC patients typically require adjuvant treatment despite technically localized disease. Stage 2 ovarian cancer, regional extension. Stage 2 ovarian cancer involves extension of malignancy beyond the ovarian tissue to involve adjacent pelvic structures while remaining confined within the pelvic cavity. This category comprises stage IIA disease, characterized by direct extension to the uterus or fallopian tubes on one or both sides. Stage IIB describes tumors that have invaded other pelvic organs including the bladder, bowel, or pelvic peritoneal surfaces. Stage IIC encompasses any stage IIA or IIB disease with malignant cells present in peritoneal fluid or washings, indicating peritoneal seeding at the time of diagnosis. Approximately 10 to 15% of ovarian cancer patients present with stage 2 disease at initial evaluation. The presence of regional extension to adjacent structures generally necessitates combination chemotherapy as part of primary treatment, even though systemic dissemination has not yet occurred. Staging accuracy at this level requires careful surgical assessment and sometimes histologic confirmation of adjacent organ involvement to distinguish stage 2 disease from stage IIA disease with minimal peritoneal involvement. Stage 3 ovarian cancer, peritoneal and lymph node spread. Stage 3 represents locally advanced ovarian cancer characterized by peritoneal surface involvement beyond the pelvis or regional lymph node metastases. This category encompasses approximately 55 to 60% of newly diagnosed ovarian cancer cases and subdivides into 3 tiers based on disease distribution. Stage IIA disease includes microscopic peritoneal metastases in the upper abdomen identified by surgical exploration or peritoneal biopsies, even when the tumor appears grossly confined to the pelvis on visual inspection. Stage IIB comprises macroscopic peritoneal metastases limited to 2 cm in maximal dimension on peritoneal and omental surfaces. Stage IIC includes metastatic deposits exceeding 2 cm in size on peritoneal surfaces, regional or paraortic lymph node involvement, or both. The identification of peritoneal spread transforms ovarian cancer from a localized pelvic malignancy into a disease requiring systemic chemotherapy as a cornerstone of treatment. Accurate stage 3 classification hinges on thorough surgical exploration of the entire abdominal cavity and systematic assessment of peritoneal surfaces and lymph nodes, which influences both prognostic counseling and treatment intensity. Stage 4 ovarian cancer, distant metastatic disease. Stage 4 ovarian cancer represents the most advanced category, encompassing tumors with distant organ metastases or other manifestations of systemic dissemination beyond the peritoneal cavity. This stage accounts for approximately 15 to 20% of newly diagnosed cases and carries the poorest prognosis among all ovarian cancer categories. Stage 4 disease includes solid organ metastases to structures such as the liver parenchyma, lungs, bone, brain, or adrenal glands. The presence of malignant pleural effusion, fluid surrounding the lungs containing cancer cells, also qualifies as stage 4 disease, indicating hematogenous or lymphatic spread to the thoracic cavity. Patients with stage 4 ovarian cancer require systemic chemotherapy as initial treatment, followed by ongoing surveillance for progression and consideration of additional therapeutic interventions. The distinction between stage IIC disease with regional lymph node involvement and stage 4 disease with distant organ metastases carries significant prognostic implications, as stage 4 patients demonstrate substantially shorter median overall survival. However, contemporary treatment approaches combining platinum-based chemotherapy, taxanes, and targeted biologic agents have improved outcomes even for patients with stage 4 disease. Diagnostic methods for accurate staging. Achieving accurate ovarian cancer staging requires integration of surgical findings, histopathologic examination, and radiologic assessment. Comprehensive surgical staging ideally involves bilateral salpingo-oophorectomy with total hysterectomy, omentectomy, peritoneal biopsies from multiple abdominal sites, and pelvic and paraortic lymphadenectomy. Intraoperative pathologic examination of acidic fluid or peritoneal washings provides crucial information about microscopic peritoneal involvement. Imaging modalities including computed tomography of the chest, abdomen, and pelvis help identify distant metastases and regional lymph node enlargement, though visual assessment alone cannot definitively exclude microscopic disease. Magnetic resonance imaging may offer superior soft tissue characterization in selected cases. Tumor markers such as cancer antigen 125, CA125, can support clinical assessment though they lack sufficient specificity for independent staging purposes. Histologic examination confirms malignancy and determines tumor grade and histologic subtype, which together with stage establish prognostic categories. The completeness of surgical staging correlates with treatment efficacy and prognostic accuracy, as occult advanced disease may be missed if staging exploration proves inadequate. Prognostic implications of stage classification. Ovarian cancer stage represents one of the most powerful prognostic predictors, with 5-year survival rates varying dramatically across stages. Patients with stage I disease demonstrate survival rates exceeding 90%, particularly when tumors are completely resected and of favorable histologic grade. Stage 2 patients achieve 5-year survival rates of approximately 70 to 80% with appropriate treatment. Stage 3 disease carries 5-year survival expectations ranging from 30 to 60% depending on the extent of peritoneal involvement and the adequacy of surgical cytoreduction. Stage 4 patients face 5-year survival rates typically below 30%, though selected patients receiving optimal treatment achieve longer survival durations. However, these stage-based prognostic estimates represent population averages, and individual prognoses depend on numerous additional factors including histologic tumor grade, patient age and performance status, completeness of surgical cytoreduction, response to chemotherapy, and specific molecular characteristics of the malignancy. Recent discoveries regarding homologous recombination deficiency and other biologic markers have further refined prognostic stratification and increasingly guide treatment selection beyond stage classification alone. Treatment planning based on stage. Ovarian cancer stage fundamentally influences treatment strategy and intensity. Patients with stage I disease and favorable tumor characteristics may avoid chemotherapy entirely following comprehensive surgical staging, whereas stage IC and higher stage patients typically receive platinum-based combination chemotherapy as part of primary management. Advanced stage patients generally undergo either neoadjuvant chemotherapy followed by interval surgical debulking and additional chemotherapy, or primary surgical cytoreduction followed by adjuvant chemotherapy, depending on clinical factors and institutional preferences. The incorporation of targeted biologic agents, including bevacizumab and PARP inhibitors, into treatment regimens increasingly depends on stage classification and other prognostic factors. Stage 4 patients may receive palliative chemotherapy aimed at prolonging survival and maintaining quality of life rather than pursuing curative intent. The staging assessment therefore constitutes the essential foundation upon which multidisciplinary treatment plans are constructed, ensuring that therapeutic intensity matches disease burden and patient goals. Recent updates and clinical evolution in staging. The FIGO staging system underwent its most recent revision in 2013, incorporating contemporary understanding of tumor biology and refined definitions based on accumulated clinical experience. These revisions improved alignment between surgical findings and prognostic outcomes, particularly regarding the classification of stage III disease and the recognition of microscopic peritoneal involvement as a distinct category. Ongoing research continues to identify biologic and molecular markers that may further refine prognostic stratification beyond traditional anatomic staging. Emerging evidence suggests that specific genetic alterations, including BRCA mutations and homologous recombination deficiency status, may eventually warrant incorporation into formal staging classifications. Additionally, the integration of genomic profiling and immunologic assessment into routine ovarian cancer evaluation may eventually lead to multidimensional staging systems that combine anatomic extent with molecular and immune characteristics. Despite these evolving insights, The FIGO system remains the gold standard for global communication regarding ovarian cancer extent and prognosis, and understanding its structure and application remains essential for all healthcare providers managing ovarian cancer patients. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.